Today class is actually there are two topics for today's class. One is retained placenta, another is postpartum hemorrhage. Are you there all? Yeah. Okay. Today we'll be focusing on the postpartum hemorrhage only because the retained placenta is another topic. I don't think I can finish it in 1 hour. If time permits, then we'll continue for retained placenta as well. Okay. So postpartum hemorrhage. Last class, now we discussed about third stage management of third stage of labor, active management of third stage of labor. What are the important things you do in third stage of labor, and what are the events that occurs in the third stage of labor. Okay. After third stage of labor, one of the most dangerous complication of third stage of labor is the postpartum hemorrhage. As I already told you, this is the hemorrhage which is very dangerous and which can kill the mother within 1 hour after delivery if it is not managed in time. So this is a very crucial stage. Postpartum hemorrhage, if you talk about the topic itself, this is actually, last time also I told you, third stage is equally important, and postpartum hemorrhage is also important. In each and every exam, you will be asked in theory and viva, practical exam, everywhere the postpartum hemorrhage is asked. So you have to be very sincerely, doing the things, noting the things, making the notes of postpartum hemorrhage, which is very important, not only for MBBS, even in the postgraduate level. Postpartum hemorrhage is the most important topic in obstetrics. Okay, so the term postpartum hemorrhage itself says that post is after, partum is parturition. Parturition is a process of labor. So after labor, if the patient has bleeding, excessive bleeding, this condition is called the postpartum hemorrhage. Simply, post after partum, parturition, hemorrhage is bleeding. So bleeding per vagina after the birth of the baby is the postpartum, actual definition of the postpartum hemorrhage. Okay. There are two types of postpartum hemorrhage. First is primary postpartum hemorrhage. Second is secondary postpartum hemorrhage. When do you call the postpartum hemorrhage primary? Is if that bleeding, excessive bleeding, which occurs after birth of the baby and within 24 hours of the birth of the baby is the primary postpartum hemorrhage. Okay. If that bleeding occurs after 24 hours of delivery till 6 weeks of puerperium or the postpartum period is the secondary postpartum hemorrhage. Secondary postpartum hemorrhage is not that dangerous in comparison to the primary postpartum hemorrhage, because if you talk about the amount of the blood loss immediately after delivery, you will have an excessive amount of the blood loss, and hemodynamically the patient will be unstable in primary postpartum hemorrhage. But in case of the secondary postpartum hemorrhage, there is bleeding, but that is not excessive bleeding, but there is bleeding in which we don't expect the bleeding. So this is secondary postpartum hemorrhage. Okay. So today we will mainly focus on the primary postpartum hemorrhage, which occurs in the first 24 hours after delivery of the baby. This is the primary postpartum hemorrhage. There are two types of the definition of the primary postpartum hemorrhage. One is quantitative definition of primary postpartum hemorrhage. Another is qualitative definition of the primary postpartum hemorrhage. Quantitative definition means the amount of the blood loss. How much of the bleeding is called the postpartum hemorrhage. Normally, if you come to obstetric clinics, and if you go into the labor room and if you see delivery conducting there, you see a lot of bleeding there, even in a normal situation. This is not postpartum hemorrhage. So how much of the blood should be lost to call it like postpartum hemorrhage? Quantitative definition of the postpartum hemorrhage is the amount which is more than 500 ml of vaginal bleeding after delivery of the baby, vaginal delivery of the baby, and if it is more than 1000 or the 1 liter of the blood after cesarean section, this is called the primary postpartum hemorrhage in the quantitative definition of the postpartum hemorrhage. So if you talk about the normal delivery or the vaginal delivery, the amount of the blood loss is around 500 ml or more, and if it is of the cesarean delivery, if the amount of the blood loss is more than 1 liter, this condition is called the primary postpartum hemorrhage. Okay. Secondary quantitative definition of the postpartum hemorrhage includes all of these features of the blood loss in the patient who has got symptoms of the blood loss as well. Okay. Qualitative definition here is something to do with any amount of the blood loss after delivery of the baby, which has got deleterious effect on the maternal conditions. That means you don't have to worry about the amount of the blood loss, because the patient is already anemic. She cannot withstand even 200 ml of the blood loss, but the patient is symptomatic with even a small amount of the blood loss. So this condition is the qualitative definition of the postpartum hemorrhage. Okay, so this you have to be clear. Quantitative definition, it is something to do with the amount of the blood loss. Qualitative definition, nothing to do with the amount of the blood loss, but it depends upon the symptoms and sign of the blood loss in that particular patient, because those patients who are already hemodynamically unstable, those patients who are already chronically ill, those patients who is already anemic cannot withstand even a small amount of the blood loss, and even a small amount of the blood loss, that patient will present to you with a sign and symptoms of hypovolemia. So this is the qualitative definition of the postpartum hemorrhage. So simply, if somebody asks you what is the definition of postpartum hemorrhage, you are supposed to answer first in the quantitative form and then the qualitative form. Okay. So what are the causes of postpartum hemorrhage? Why the patient bleeds heavily after delivery? Okay, you have to understand the physiology. Why this patient is, so there are two patients. One patient is just delivered normally. She has a normal amount of blood loss, less than 500 ml of the vaginal bleeding. This is not PPH. Another patient is delivering, but she has excessive amount of blood loss. Why? What is the cause of that excessive amount of blood loss in those particular patients? Okay, there are various causes of the postpartum hemorrhage, primary postpartum hemorrhage. First and the most important cause of the postpartum hemorrhage is the atonicity of the uterus. In last class also we talked about the tone of the uterus, which is very important for the third stage management, and similarly tone of the uterus is important for the prevention of the postpartum hemorrhage also. Okay, so if the uterus has no tone, that means the atonic uterus is the most important cause of the primary postpartum hemorrhage. Okay, second cause is the genital tract injury. Genital tract injury can be of the different types. It can extend from the fundus of the uterus to the perineum. Different types of the injuries in the genital tract. There may be a rupture of the uterus, there may be a cervical tear, there may be a vaginal tear, there may be a perineal hematomas, things like that. These are the different types of the trauma we see in the female genital tract after birth, and that can lead into the excessive bleeding in the post-delivery period. Okay. Next is the third is the retained bits of the placenta or the membrane. Sometimes everything is there, atonicity is not there, genital injury is not there, but sometimes a bit of the small chunk of the placenta can adhere in the uterine wall, which hampers the coagulation mechanism and the tone of the uterus, and the patient can bleed heavily and cause postpartum hemorrhage. Another cause of very rare cause of the postpartum hemorrhage is the coagulation defect of the various types. Maybe the patient already has some coagulopathy that is leading to the coagulation defect, and the patient is bleeding heavily. So this is a rare and the last cause of the primary postpartum hemorrhage. Okay, so these are the basically different causes why the patient after delivery of the baby bleeds heavily. The most important in 80% of the patient, this is due to the atonicity, that is a lack of the uterine tone as a result of the absence of the uterine wall muscle contraction. Clear? Are you there? Is it clear?
Yes, ma'am.
Okay. This slide, just closely look at this slide. This is just to make it easy for you guys to understand, easy to remember what are the causes of postpartum hemorrhage. There are 4 T's. First T is the tone of the uterus. I told you about the atonicity. Okay. Second is the genital tract injuries in the form of the second T is the trauma to the genital tract, right? Third T is the tissue in the uterine cavity in the form of the retained bits of the placenta is a tissue in the uterine cavity. and the last is the coagulation defect in the form of the last T is the thrombus formation. That is something to do with the coagulation factors. Okay, so this slide shows the 4 T's, which makes you understand, which makes it easy to remember the causes of the primary postpartum hemorrhage. 4 T's. So again, this slide shows the same thing, starting from the common cause of postpartum hemorrhage to the coagulation, which is about very rare and sometimes it happens also. Okay. So close look at this slide closely. There is something you have to understand. What is it? Is the uterus is full of fetus, and there is a placenta attachment. Okay, this is the uterus vertex presentation, cephalic presentation, fetus in the uterine cavity. This is the umbilical cord. This is the placenta, right? Normally, what happens is if during pregnancy, this during pregnancy, even after delivery also, if after delivery of the baby, what happens is, I told you in the third stage of labor, the uterine muscle starts contracting. When the uterine muscle starts contracting, this placenta starts separating from the uterine wall, and the placenta is delivered in the expelled in the third stage of labor. Okay, and this is as a result of the uterine contraction. And after delivery of the placenta, or even during the process of the placental expulsion, what happens is, if you look at this photographs, these are the blood vessels which are connected to the umbilical cord, and these are the chunk of the bunch of the blood vessels which are also connected to the umbilical cord. And this side of the this side is a maternal side. This is the uterine wall. So when the placenta is expelled or separated, this whole of the chunks blood vessels are taken out. The remaining part of the cavities on the wall of the uterus are full of blood. These are the pool of the blood covered here when the placenta is expelled, and if the uterus is not contracted through that pool of the blood, sinuses of the blood, the patient will heavily bleed. Okay, so this is where the patient starts bleeding immediately after delivery. So you have to be very clear that patient does not bleed from other sides, like doesn't bleed from here, doesn't bleed from here. Okay, after delivery of the placenta, the patient starts bleeding from the placental attachment site, which are opened if the uterus is not contracted. And that because of the non-contracted uterus, there are a pool of the sinuses of the blood on the uterine wall, from where the patient starts pouring blood, that the PPS will occur. So you have to understand this, because of the placental site is very crucial site immediately after delivery, which has to be closed by uterine contraction. If it is not there, then the patient will start pouring blood and there will be PPH. Again, this is the same thing. This is the umbilical cord, and these are the big sinuses which gets opened after placental separation, and the patient starts bleeding. Okay, so what are the mechanism of the stoppage of the normal stoppage of the bleeding after delivery of the baby? Okay, normal mechanism, there will be no bleeding. If there is nothing like there is no normal mechanism, something is wrong with all these factors, then the patient starts bleeding. Okay, so first you have to understand what are the factors which causes stoppage of the bleeding after delivery of the placenta or the delivery of the baby. Okay, first thing is the constriction of the blood vessel. It happens everywhere. Somewhere, if you get an injury on your hand, that there will be a constriction of the blood vessels, that will be followed by the clot formations, and the bleeding will stop. That happens in the uterus as well. So the first and the most important thing is the constriction of the blood vessels itself. The wall of the blood vessels go on contracting, and because of the response to the injury, and the bleeding will stop. That is first mechanism. It happens everywhere. Second is the clot formation. If the coagulation cascade is normal, coagulation factor is normal with that particular patient, the patient will have a clot formation and the bleeding will stop. That also occurs everywhere. Another additional thing which happens in the uterus is, because of the uterine contraction, blood vessels in between the uterine muscle fibers will be entrapped in these contracted muscles, and there will be kinking of the blood vessels, which is the major factor in the stoppage of the bleeding in postpartum period. Okay, so this is the most important factor for the prevention of postpartum hemorrhage. So this slide shows how the contraction of the myometrial fibers helps in the prevention or the stoppage of the bleeding after delivery. In this figure, what happens, there are the long muscle fibers. These are the myometrial fibers. Some are longitudinal, some are circular, some are oblique muscles. There are three layers of the muscles in the uterine wall. When these muscles are contracted, when these muscles, long muscles are contracted here, and they become short and thick. Okay, so because of that, wait a minute, please. Okay. So this is a blood vessel. Suppose this is a blood vessel going through the wall of the myometrium, and these are the different layers of the myometrial muscles. At this moment, the uterus muscles are not contracted. When these muscles are contracted, it becomes thick and shorter and thicker. And because of that contracted myometrial muscles, the blood vessels is kinked here. So the blood flow through these vessels are obstructed, and the patient will have no bleeding. So this is how the mechanism of how the bleeding stops immediately after the delivery of the baby. Okay, so this is the most important factors in the prevention of the postpartum hemorrhage. I told you there are 3 layers of the muscles in the uterine wall. Okay, this is the same. I discussed about the mechanism. This slide also shows the same thing. There are blood vessels passing in between the muscle fibers. After delivery of the baby, intrauterine volume is suddenly decreased. As I talked in the last class also, because of the delivery of the baby, intrauterine volume is decreases like anything, because around 2.5 to 3 kg of the baby is delivered, which stimulates the shortening or the contraction of the muscle fibers. This is called the uterine contraction. We also call living ligature, and resulting in the entrapment of the blood vessels which are passing through the muscle fibers. So this is how the bleeding stops immediately after delivery. Okay, there are certain hard facts in the postpartum hemorrhage. Globally, around 10% of the women have postpartum hemorrhage immediately after delivery, and duration between the onset of the massive bleeding is around 1 to 2 hours. If this is not managed in time, the chances of the maternal death is there. 14 million women, they are affected by the this type of different types of the different degrees of postpartum hemorrhage, and in India and Nepal, around 20% of the maternal deaths is due to the postpartum hemorrhage. So this slide shows the amount of the blood loss and the symptoms and signs of the blood loss. This applies everywhere, any type of the bleeding. It applies to the GI bleeding, it applies to the other type of the injury-related bleeding. So everywhere when the patient is losing blood, and if you correlate with the loss of blood and the signs and symptoms of bleeding, then the slide clearly shows that when there is less than 500 ml of the blood loss, which is about 10%, less than 10% of the total blood volume, the patient will not have any symptom. Okay. The second is the alert line is there. After 500 ml, around 1 liter of the blood loss, the patient will have minimum sign and symptoms of the blood loss. When it exceeds the 1 liters to 1.5 liters of the blood loss, around 25% of the total blood volume is lost. The patient starts having all the features of the hypovolemia in the form of the decreased urine output, increased blood pulse rate, respiratory rate, and sometimes the patient presents to you with postural hypertension and the narrowing pulse pressure if you examine the patient. Okay, so when this type of the overt symptoms will start appearing, when the patient lose around 25% of her total blood volume, and the symptoms will like the peripheral perfusions and the central perfusion will be affected, and the patient will have all the features of the decreased blood volume, and that is you have to demarcate it as in the action line of the blood loss and the symptomatic relationships. Okay, When the patient lose around 2 liters of the blood loss, like 1.5 to 2 liters, which accounts around 30 to 30% of our total blood volume, then the patient will have a severe hypotension, patient will have a tachycardia, patient will be in shock, cold and clammy extremities, and tachypnea. These are the features of the shock. And when this is more than 2 liters of the blood loss, around 40% of the total blood volume is already lost. The patient will be in the profound shock, hypovolemic shock. So this slide shows the amount of the blood loss and the different signs and symptoms of the blood loss. And around, you have to look up like how is the general condition of the patient in the previously before delivery. You have to correlate that or truth. If I told you in the qualitative definition, then there is nothing to do with the amount of the blood loss. So you have to see the symptoms and sign also. Even 500 ml blood loss can cause symptom and sign for those patients who are already hemodynamically compromised. So this slide is something to do with the amount of the blood loss and the sign and symptoms of the blood loss. Okay. This slide shows when a patient is pregnant and she is coming for regular antenatal checkup, there are certain risk factors you can find out. You can anticipate this patient can have a postpartum hemorrhage during delivery. So you have to rule out certain risk factors. You have to counsel the patient. There is a chance of having excessive bleeding during delivery. You have to arrange blood. You have to do everything. You have to get ready for the delivery. So what are the risk factors you can anticipate previously in antenatal period, so that you can manage the patient properly during delivery and postpartum time. So antepartum risk factors, labor risk factors, and the certain surgical interventional risk factors. This is divided into 3 groups. Okay, antepartum risk factors, you have to take history of that patient, you have to examine the patient, you have to do investigation of the patient, and there are a long list of things which can give you some clue that the patient can have a postpartum hemorrhage. What are the history you ask in the patient who is likely to have like postpartum hemorrhage, to find out whether this patient having predisposing factors for postpartum hemorrhage or not. Okay, so history of the postpartum hemorrhage is very important. Those lady who had postpartum hemorrhage in the past pregnancy is having 10% chances of having postpartum hemorrhage in the subsequent pregnancy delivery. So you have to ask the history of the postpartum hemorrhage in the previous pregnancy as well. Okay, so another is nulliparity. That means the first pregnancy that is towards the extreme of the age. Elderly primary gravida, they are likely to have a postpartum hemorrhage if you compare to the other patient. So patient elderly primary, which is around after the age of 35, they are likely to have a fibroid uterus that predispose the patient to have postpartum hemorrhage. Another risk factors is a grand multipara. That means a woman who has given birth of 5 or more children, that patient is likely to have a postpartum hemorrhage because of the atronicity. If you compare a patient with a second gravida and another patient having the 5th gravida, the chances of having postpartum hemorrhage in the 5th gravida is definitely more than the second or the 3rd gravida. So you have to ask the obstetric history properly. Okay, other things like I told you about the coagulation factors. Sometimes the patient is maybe suffering from the certain type of coagulopathy, that is maybe patient is getting treatment, or the patient is having heart disease and anticoagulation therapies for some other reason. So you have to ask the history properly about the coagulation defects and any medication taken for that particular problem. Okay, history of coagulopathies and medical treatment has to be noted down properly. Another is abnormal placentation. Okay, abnormal placentation भनेको के, normally the placenta is situated in the upper or the upper segment of the uterus. This is the normal placentation. If the placenta is localized in the lower segment of the uterus, this is an abnormal placental attachment which predisposes the patient for postpartum hemorrhage. When the placenta is attached to the lower uterine segment, this condition is called the placenta previa. Okay, the placenta previa is the one of the risk factor for the postpartum hemorrhage. that placenta previa को छुट्टै क्लास हुन्छ 6 or 7 सेमिस्टरमा. This is a huge topic, and by at this moment you have to know the placenta previa is the implantation of the placenta in the lower pole of the uterus, which is a risk factor for postpartum hemorrhage. Okay. Other risk factors like patient is already anemic. I told you the anemic patient cannot hold even a small amount of the blood loss, so she will become symptomatic. Another risk factors is the over distension of the uterus. Normally, the uterus is distended in pregnancy. It contains, if you talk about the single-term pregnancy, it contains fetus, it contains amniotic fluid, it contains placenta. So the uterus is distended. This is a normal distension of the uterus. Where there are more than one fetus, like in multiple gestation, if there is a more than normal amount of the amniotic fluid, this is called polyhydramnios. If there is something defect or something wrong with the placenta, and the uterus will be over distended. That means the content of the uterus is exaggerated because of the multiple pregnancies, polyhydramnios, things like that. It causes over distension of the uterus. Because of the over distension of the uterus, the elasticity of the muscle fiber is lost, and immediately after delivery of the baby, the uterus will not contract properly, and the patient will have atonicity, and the patient will have postpartum hemorrhage due to atonicity. Okay, this is how over distension of the uterus causes primary postpartum hemorrhage. Okay, so these are the things which has to be anticipated on the antenatal period by history, by investigations, and by examination. You have to ask certain history. You have to ask the obstetric history, obstetric deliveries, how, where, and how many deliveries she had in the past, whether she had PPH or not. You have to examine the patient for anemia or the chronic diseases. You have to examine the patient for multiple gestation, polyhydramnios, or sometimes fetal microsomia, big babies, which can predispose the patient for postpartum hemorrhage. Okay, so these are the antenatal risk factors. Labor risk factors, there are certain labor risk factors. You are conducting a delivery, you are taking delivery in the labor room. There are certain conditions that during that labor also which increases the chances of having postpartum hemorrhage. The first is the prolonged labor. Okay, labor stages are divided into 4 stages. I told you in the last class also, and it has got like first stage, it has got a certain time limit. How long should it be? Second stage, it has got a time limit. Third stage, it has a time limit. Okay, when the labor is prolonged, that means the expected time if the labor is prolonged for a long time, that patient is likely to have postpartum hemorrhage. The reason behind that is the myometrial muscles fiber, they go on exertion, and the uterus will not contract immediately after delivery of the baby. Okay, so this is a prolonged labor predisposes the patient for postpartum hemorrhage. This is the most important labor risk factor which predisposes the patient for primary postpartum hemorrhage as a result of atonicity. Okay. Second is the certain medical conditions like preeclampsia and other renal diseases, coagulation defects, patient is diabetic, certain heart diseases, things that they will increase the chances of postpartum hemorrhage to some extent also. And while you take the delivery, you have to properly examine the all the systems of that particular patient to find out whether this patient is having different types of medical conditions or not. Okay. Other things like the fetal demise, that means the baby is dead baby, patient is delivering dead baby. We don't know where the baby dies, and there may be chances of infection. Because of that infection, that patient can have a postpartum hemorrhage. Okay. Another is the patient was induced or augmented. Okay, labor induction and augmentation are the 2 terms which are used for the delivery purpose. And induction of the labor and augmentation of the labor, today class again you should know that those patients who were induced labor and augmented labor having chances of postpartum hemorrhages there. Use of magnesium sulfate. Magnesium sulfate is one medication which is given for the high blood pressure in pregnancy and eclamptic seizures in pregnancy as an anticonvulsant, which increases the chances of having a postpartum hemorrhage. So you have to know whether this patient is given magnesium sulfate or not to find out the risk factors for postpartum hemorrhage. Another is chorioamnitis. Chorioamnitis is a condition where there is infection in the chorion and amniotic membrane, which predispose the patient for postpartum hemorrhage. Okay, so these are the list of risk factors, labor risk factors related to postpartum hemorrhage. So there are certain surgical intervention which we do in the delivery process, and this surgical intervention also increases the chances of having postpartum hemorrhage. First is the operative vaginal delivery, that in the form of instrumental delivery. So we apply vacuum delivery, we apply forceps delivery in order to take out the baby. So this is the operative vaginal delivery. During instrumental or operative vaginal delivery, there is a chance of genital tract injury leading into the excessive bleeding after delivery. Another is surgical, like a cesarean section, which it also predisposes the patient for having postpartum hemorrhage. And sometimes episiotomy given in the perineum in order to have an easy vaginal delivery can lead into the excessive bleeding, and that patient is having the postpartum hemorrhage. Okay, so this slide shows basically three types of the risk factors. You have to, as a physician, as an obstetrician, as an on-duty doctor, you have to look upon all these different three categories of risk factors for postpartum hemorrhage, and so that you can be prepared for the management of the postpartum hemorrhage. Antepartum risk factors, intra-labor risk factors, and the certain surgical intervention which increases the chances of blood loss after delivery. Okay, so it has to be clear. This factor has to be sought out in time and managed accordingly. Again, these are the common risk factors. They were the, in previous slide, there were the different categories, but these are the commonly seen risk factors in the day-to-day practice. We usually see the poor general condition or the poor maternal health is the most important risk factors in our part of the world. Another is big baby, maybe associated with the diabetes mellitus. Another is polyhydramnios. We commonly see over distension of the uterus. Sometimes we see the multiple pregnancies, twin pregnancies, pregnancy also related to the over distension of the uterus, previous uterine surgery in the form of the most commonly previous cesarean section, which also increases the chances of postpartum hemorrhage, prolonged labor, and instrumental deliveries. These are the common risk factors for the primary postpartum hemorrhage. Okay. All right. We will first talk about the atonicity of that. We talked about the incidence of the postpartum hemorrhage, how the bleeding stops immediately after delivery. We talked about it. We talked about the different risk factors of the postpartum hemorrhage. We talked about the different classification, primary or secondary postpartum hemorrhage. Now we are focused on the in the causes of postpartum hemorrhage. The most important cause of the postpartum hemorrhage is the atonicity. Okay, most of the things I told you in the risk factors also, why the uterus become atonic. Okay, this is the major cause of the postpartum hemorrhage. Over distension of the uterus, stretching of the muscles to some extent regains its elasticity, as you all know, but overstretching beyond certain level does not allow its normal shortening mechanism, resulting in the lack of the effective contraction. When the uterus is not contracted, big sinuses remains open, as I showed you in the previous slide, and from where the patient starts pouring blood, and the patient will have postpartum hemorrhage. Okay, this is the mechanism how atonicity causes excessive bleeding. Okay, another cause of the atonicity is, like, there is a myoma. This is a tumor of the myometrium, also called the fibroid uterus. There are various irregular fibers, excessive growth of the myometrial muscles, which causes dearrangement of these regular muscle fibers, and because of that irregular muscle fibers, uterus does not contract properly. So the patient with pregnancy with a fibroid uterus, chances of having a postpartum hemorrhage due to atonicity is there. So you have to find out in an antenatal period whether this patient has fibroid or not. Okay, which predispose the patient for postpartum hemorrhage. Okay, other things like the uterus is congenitally defected uterus. There are various types of the congenital defect of the uterus, maybe of the bicornuate uterus, maybe of the unicornuate uterus, maybe of the septate uterus. So there are various abnormalities, this congenital defect of the uterus, in where we expect the myometrial muscles are not in a regular basis. So irregularly arranged myometrial muscles will go into the atonicity immediately after delivery. So congenital abnormalities of the uterus also causes atonicity of the uterus. And chronic diseases like patient is anemic, a patient is COPD, having hypoxia for a long time, because of all these pre-existing conditions, the patient will have atonicity. So these are the causes of atonicity in the postpartum hemorrhage. Okay, so how do you diagnose a case of atonicity immediately after delivery? In third stage of labor also, I told you there are the various methods. You see how the uterus is contracted or not. First is the patient is profusely bleeding is the one of the sign of atonicity. Okay, because in traumatic bleeding, this is not profuse bleeding. When the patient is profusely flooding, like pouring blood, you have to suspect the patient has got atonicity. Another is feature of the blood loss. As soon as the patient starts pouring, then she will have all the features of the blood loss according to the amount of the blood loss. I told you in the last slide also. If the patient is having tachycardia, patient has a low blood pressure, patient starts like looking pale. Also, patient extremities become cold because of all these features of the blood losses there, because of the pouring of the blood from the open sinuses as a result of the lack of the uterine contraction. Okay, after that, when you see the pouring of the blood, you have to feel the uterus just above the symphysis pubis. I told you in the last class, if the patient is lean and thin, you can see a contracted uterus standing just above the symphysis pubis. That is a globular and hard uterus just above the symphysis pubis is the contracted uterus. When you feel the uterus, you don't feel the contracted uterus. This is a flabby uterus, and you cannot make out the size of the uterus also, because the uterus is flabby. Okay, so this is the one sign of the atonic uterus. You cannot find out the firm and hard uterus standing just above the uterus. The size of the uterus is also not that clear because of the lack of contraction. So you have to examine for abdominally to find out whether the uterus is contracted or not. Okay, after that, you have to examine the genital tract to see any injuries in the genital tract. Patient is pouring, maybe the more than one factor is playing a role in that bleeding. Maybe the uterus is not contracted, as well as there may be genital tract injury also. So you have to rule out certain type of genital tract injury. You have to visualize the cervix. You have to see the vagina, whether there is vaginal tear or not. You have to see the perineum. You have to see the episiotomy site, whether the patient is bleeding from there also. So explore the female genital tract to see the injury in the genital tract. Okay. After that, if there is no injury, then the diagnosis of atonicity is made, and your aim here is to bring the uterine contraction. Start giving uterotonic medicine. When you are confirmed this is due to the lack of the tone of the uterus, then you start giving uterotonic medicine as soon as possible to bring the uterine contraction, which is the main culprit for the bleeding, excessive bleeding after delivery of the baby, causing postpartum hemorrhage. Okay. So what are the medication you can give? Like in last class also, third stage of labor, we talked about different types of uterotonic medicine which increases the uterine contraction. The first and the physiologically acting uterotonic medicine is the oxytocin. We usually give in the form of the intramuscular or intravenous injection, and that can be given as in the dose of 10 units bolus, that is given directly into the vein, or you can give into the intramuscular injection, or you can give in the infusion also. Okay, so infusion means you can dilute it with some saline and then give slowly intravenously is the infusion route of administration. Okay, so oxytocin can be given whatever uterotonic medicine is available. You have to start giving when the atonicity is diagnosed. Next medication is the ergometrin, methyl ergometrin, in the form of the injection that is given intramuscularly, and this is in the dose of 0.2 milligram, and that is a good medication for the postpartum hemorrhage. As I told you in the last class, it causes tonic uterine contraction and it stops bleeding immediately. If you compare with the oxytocin, it causes a rhythmic contraction, and ergometrin causes tonic contraction. So it causes stoppage of the bleeding faster than the oxytocin. Okay, but it has got certain complications and limitations. Ergometrin cannot be given to those patients who have got high blood pressure and heart disease. So you have to exclude these two conditions before giving ergometrin. But this is a very nice medication for the management of the postpartum hemorrhage. Okay, so there are other medications like I told you in misoprostol, post different types of prostaglandins in the form of the tablets, injections, sometimes gel also. So according to the availability, you can go for the misoprostols that can be given. Usually what happens is in the postpartum hemorrhage, patient is bleeding heavily through the vagina. We give the misoprostol tablets parenterally, which has got faster action than the oral tablet. So we can give 800 microgram of the misoprostol parenterally, which is supposed to act within 5 minutes of the administration, and the patient will have uterine contraction and the bleeding will stop immediately. So this is the oral medication, very nice medication, very cheap medication, which has saved many lives because of the postpartum hemorrhage. Misoprostol tablets 800 milligram parenterally in the case of the primary postpartum hemorrhage. Okay, so other medications like in the form of the dual medication, which can be used in the form of the injection. Sometimes if these measures, these other protonic medication does not help, then you can directly inject the protonic medicine into the uterus directly through the abdomen. Okay, the uterus is, you can just localize the uterus and directly through the abdominal wall you can inject into the myometrium, which stimulates the uterine contraction. That is as a result of the direct injection into the myometrium, causing uterine contraction in case of postpartum hemorrhage due to atonicity. So it helps a lot this is the last resort for the management of the atonic uterus in the form of the uterotonic medications. Okay, so these are the different types of medication you can give for the atonic postpartum hemorrhage, primary postpartum hemorrhage. Okay, the next step, what do you do is, if the patient is getting all the uterotonic medications and the patient is still bleeding, the uterus is not that contracted. So we have to go for the next step of the management, how to bring the uterine contraction and how to stop the bleeding. Okay, the next is we do the uterine massage. When you are taking delivery in the labor room, you are towards the leg end of the patient, you are standing in between the two legs of the patient taking deliveries. You have to put your left hand to the suprapubic region and massage the uterus. Okay, when you massage the uterus, it stimulates the contraction of the uterus. Massaging the uterus brings about to some extent contraction of the uterus, and it helps in the to bring the tone of the uterus in case of atonic postpartum hemorrhage. Okay, the next is bimanual compression. There is a term called bimanual compression. Bimanual means you use your two hands and causes compression of the uterus. You put your one hand in the vagina, right hand in the vagina. You put your left hand in the suprapubic region and feel the uterus and try to bring the uterus in between the vaginal hand and abdominal hand. That means that try to compress the uterus in between the two hands. This is called the bimanual compression. So because of that, the bleeding sinuses gets compressed and the patient will have a decrease or thus stop bleeding. Okay, this is the bimanual compression done with the help of your two hands. One hand is in the vagina, one hand in the suprapubic region. In between the two hands, they bring the uterus and press it so that the sinuses are pressed and the patient will not have bleeding or the stop bleeding. This is the bimanual compression. Okay, another is the compression is the same to as the bimanual. This is the aortic compression. If that does not help, some patient, very lean and thin patient, you can feel the aorta just above the at the region of the umbilicus, and you can just compress the aorta with your fist and decrease blood supply to the uterus, and because of the uterine blood flow decrease, the patient will have decreased bleeding. Okay, so this causes that it as a result of the decreased blood supply to the through the uterine artery, and perfusion to the uterus is decreased and the patient will have a less bleeding. This is aortic compression, another compression method for the management of the primary postpartum hemorrhage. Okay, so these are the different types of compression compression you give from outside. There are certain type of the compressions or the pressure you can give through the inside also. That means through the uterine cavity also. Okay, if the patient has just delivered and she has profusely bleeding, I told you, I showed in the last slide, the big sinuses are open. So our aim is to cause compression to that sinus. That can be done from outside, as I have the first three steps we do, and the last is from the inside. Sometimes you can go with the gauze pad packing in the uterine cavity. Because of that gauze pad packing, it causes compression to the open sinuses, and the blood flow through that sinuses will be decreased and the patient will have a less bleeding. Similarly, you can put a balloon catheter in the uterine cavity and inflate with the water or the saline, which also causes physical pressure from inside the uterine cavity, and the bleeding will be decreased. Okay, so this is an intrauterine compression. So compression can be given from the outside also, from inside also. From outside, you can do the massage of the uterus, bringing the uterine contraction. You can do the compression of the uterus in between two hands by bimanual compression. Third is you can just press on the aorta, which decreases the blood flow to the uterus and decreases the blood. From inside, you can put the balloon catheter, or you can put the gauze pad inside the uterine cavity, causing direct pressure to the open sinuses, which helps to some extent to stop the bleeding. Okay, and there are other things, like there are certain compression sutures that can be given in the uterus in order to tie the uterus. If the uterus is not contracted with all these measures, then you can just tie the uterus in order to compress it so that the bleeding will stop. Okay, so these are the different physical pressures given in case of the atonic uterus causing primary postpartum hemorrhage. Okay, this slide shows bimanual compression. I told you this is the hand, one hand in the vagina, another hand in the suprapubic region. So bring the uterus in between the two hands so that these vessels, open sinuses, are closed, and the patient, by that time, the coagulation factors will act, and the patient will have a clotting mechanism also, and the patient will stop bleeding, hopefully. Okay. This is how you do aortic compression. You just make your strong fist, and just above the fundus of the uterus, you just press directly to the aorta, which is supposed to decrease the blood flow to the uterus and decrease the blood loss also. So these are the different types of balloon catheter, which can be inserted into the uterine cavity and inflate either with the air. Usually we inflate with fluid and saline and other fluid, which causes direct compression to the uterus and open sinuses and stops the bleeding. Okay, these are the intrauterine compression methods used for the stoppage of the bleeding in primary postpartum hemorrhage. And so this is a condom tamponade. This is the same as a balloon catheter. We insert a rubber tube inside the uterine cavity, and we connect this with the fluid, and we just let the fluid go inside the uterine cavity and causes compression to the uterine cavity. This is also a type of balloon tamponade. This is in practice nowadays. It has a very good effect in the prevention, in the management of postpartum hemorrhage, refractory type of postpartum hemorrhage. Okay, these are the last. I told you about the different type of sutures can be given in order to tie the uterus. Uterus is not contracting. You have done everything. You have done uterine massage. You have given all the uterotonic medications. You have done all the pressure from outside and inside. Still, the patient is bleeding. The uterus is not contracted well. So your aim is now to just tie the uterus. Okay, so that when you tie the uterus, it causes pressure to the open sinuses, and again it will stop the bleeding, hopefully. So this is the last compression things we do in the management of postpartum hemorrhage. This is a type of suture. Its name is B-Lynch suture, which is usually started with the case of postpartum hemorrhage with cesarean delivery. This is a cesarean wound. Okay, and the patient cesarean wound is already closed. The patient is having continuously bleeding. So what do? Is we give a suture from anteriorly and posteriorly, and we tie it here so that the uterus is is made a small size because of the compression from all around. So the bleeding will stop. So this is a B-lean suture. At this point of time, at this moment, for you guys, for MBBS, this is all you need to know about compression suture. There are many compression suture, newcomers for compression suture, and which needs expert hand to use. But at your level, you have to know the B-lean suture, which is the pioneer of the compression sutures. You should know about this type of suture. How does it help in the management of postpartum hemorrhage? Okay. So this is till this slide. We discussed about the different causes of tonicity and what do you do once you diagnose the tonicity. What are the steps you take to bring the tone of the uterus, and how do you manage a case of different modalities of the treatment you give for a tonic postpartum hemorrhage. Next T is the trauma to the genital tract, which is the second common cause of the primary postpartum hemorrhage. Okay, trauma to the genital tract can be of the, I told you, it can be from the starting from the fundus to the perineum. Uterine injury can be in the form of the ruptured uterus, or those patients who had a previous cesarean section. There may be a dehiscence of the previous scar that can lead into the postpartum hemorrhage. Other things like cervical tear, which is a very common genital tract injury causing postpartum hemorrhage. Most common genital tract injury causing postpartum hemorrhage is the cervical tear, cervical injury. Remember, what is the most common traumatic cause of the primary postpartum hemorrhage is the cervical tear or the cervical injury in the form of the laceration or the tear. Okay. Next is when you come down from the cervix, there may be chances of vaginal injury in the form of the tear, laceration, or sometimes if there is nothing on the surface, there may be the hematoma formation. That means the deep blood vessels of the vagina got ruptured and there is a collection of the blood in the just below the vaginal mucosa. There is a bluish discoloration swelling in the vagina in the form of the hematoma. Okay, so this is the vaginal injury, and there are different types of the perineal injury depending upon the degrees, the muscle involvement of the muscles or not. There are different degrees of the perineal tear, and these are the different types of the genital tract injury leading into the primary postpartum hemorrhage. Okay. Cervical tear, which really heavily bleeds. Okay, if you see a patient with heavy bleeding and you find the uterus tone is normal, there is no tonicity, the next thing you suspect is a cervical tear. So you have to examine the cervix properly to find out whether this patient has a big cervical tear or not, because the cervix is supplied by the descending branch of the uterine artery, which is really a big and dilated blood vessels during pregnancy and delivery. When there is tear on the cervix, that descending branch will heavily bleed and the patient can go into shock. So cervical tear has to be ruled out. You have to examine the baby properly, and there are certain risk factors for cervical tear also. If the patient has delivered big baby and the patient has precipitate labor, that means with too fast delivery can lead into cervical tear also. This is called precipitate labor. So these are the factors which predispose the patient for cervical tear also, genital tract injuries. Okay, the cervical tear is the most common genital tract injury causing primary postpartum hemorrhage. Okay. So this slide shows cervix, which is normally this is post-delivery cervix. She has just delivered a baby, so this is like baggy things, not a firm, nice cervix. This is a baggy, distended things, soft things. So the patient can have a cervical tear either on the angle of the cervix, and from there she bleeds profoundly. Okay, so these are the cervical tear. Okay. So you have to suture the cervical tear according to the site of the injury. This has to be sutured properly, otherwise the patient will go into shock. Okay. Perineal tear, different types of the perineal tear. Again, it has perineal tear different class different degrees. For that, you should know the muscles of the perineum. anatomy of the perineum, what are the things, what are the layers in the perineum, and depending upon the injury to the layer of the perineum, this is divided into different degrees of the perineal tears. That can be of the first, second, or third, and lastly the fourth degree of the perineal tear. That depends upon the involvement of the certain structure and the muscles of the perineum. So for that, we will have another class. Just you have to be sure that there is a chance of having postpartum hemorrhage predisposed by the perineal tear also. So you have to examine for the perineal, different degrees of the perineal tear, to rule out the traumatic cause of the postpartum hemorrhage as well. Okay. So to have some knowledge about the perineal tear, this is like this is the post-delivery vagina, and this is the suture vaginal skin. This is first degree. This is the lacerated part, and this is the final suturing of the perineal skin. Okay, this is the how you tear, how you repair the perineal tears in post-delivery patient if she has perineal tear and episiotomies. Okay, fourth degree perineal tear is a dangerous type of perineal tear. This is the vagina. This is the anus. There is a communication between the vagina and anus, and the anal sphincter is torn out. So this is the fourth degree perineal tear. It has extended up towards the rectum also. Okay, so this is a dangerous type of the perineal tear. Sometimes that can lead into the primary postpartum hemorrhage as well. Okay, so this is a abdominal picture of the broad ligament hematoma. This is a uterus. Okay, there is some injury in the uterine wall from where the blood is oozing towards the broad ligament. Broad ligament actually is a layers of the two layers of the peritoneum. In between these two layers of the peritoneum, blood gets accumulated, and there is a formation of the hematoma. This is another type of the trauma to the genital tract. Though this is a rare type of a condition, but it can sometimes, it's difficult to diagnose and manage. So patient can present to you in shock, and sometimes patient can die without diagnosis also, because nobody think about this condition, which is very rare condition. Okay, so what happens is during the process of the delivery, there are a rupture of the blood vessels here on the side of the wall of the uterus, that is leaking in between the two fibers of the peritoneum, which is a broad ligament, and there is collection of the blood. Nobody thinks about it. Okay, unless you see bleeding from the vagina. In this case, you don't see bleeding from the vagina, but there is accumulation of the blood outside the uterus, and the patient is in the shock. So this is a very dangerous condition. It's called the broad ligament hematoma. This is how you see, like this is the uterus. You open the abdomen, and there is a formation of the hematoma on the side of the uterus. This is how you see on the normal scenario of the broad ligament hematoma. Okay, so this is about the trauma to the genital tract. Different types of the trauma, and according to the different types of the trauma, it has to be prepared for the management of the postpartum hemorrhage. Next T is the tissue in the uterine cavity. What is the tissue, possible tissue in the uterine cavity after delivery of the baby? Baby is delivered. Okay, amniotic fluid is drained out. Placenta is delivered. Sometimes there are some pieces of the placenta or the membrane in the uterine cavity which can have a postpartum hemorrhage. Okay, that has to be ruled out. That's why I told you in the last class, in the third stage of labor, only different steps you take in the active management of third stage of labor. Last step is to examine the placenta and the membrane to find out whether this is complete or not. You have to be sure that the whole of the placenta is taken out, whole of the membrane is taken out, so there is nothing in the uterine cavity. There is no tissue in the uterine cavity, so that has to be ruled out. Okay, so once the patient is having bleeding PV, the uterus is contracted, there is no genital tract injury, you have to go back to the placenta and again examine whether the placenta is complete or not. If it is complete, you can be sure. Even if it looks complete, you have to explore the uterine cavity. You have to insert your hand in the uterine cavity, because the cervix is wide open at this time. When she has just delivered a baby, you can put your hand inside the uterine cavity and you feel there if there is something tissue or some abnormal things in the uterine cavity. That is called the exploration of the uterus, to see any pits of the placenta or the tissue in the uterine cavity. Okay, so that has to be ruled out to find out whether the tissue is the factor for causing postpartum hemorrhage. hemorrhage. If there is some tissue, abnormal tissue, placental chunk in the uterine cavity, that has to be taken out, and you have to give uterotonic medicine for the uterine contraction again. Okay, so that is for the retained bits or retained placental membrane in the uterine cavity. Okay, the last T is the thrombin. I told you, according to the patient history, if the patient has coagulation factor problem, maybe have a thrombocytopenia, or the patient is taking anticoagulant medications, that has to be addressed accordingly. You have to screen for the coagulation factors. If everything is normal, patient is continuously bleeding, uterus is contracted, no trauma, no bits of the placenta, you have to suspect the coagulation defect and investigate accordingly. And according to the investigation's results, you have to take the patient. Okay, so that depends upon the investigation center for the coagulation factors. Okay, so this from this slide you have to be very careful. This is like a question out. You will be asked in each and every exam, how do you manage a case of the postpartum hemorrhage, primary postpartum hemorrhage. These are the stepwise manner we do for the management of the postpartum hemorrhage. Whatever is the cause of postpartum hemorrhage, whichever is T is there, doesn't matter, but you have to manage a case of postpartum hemorrhage. Okay, so these are the steps wise manner you have to write, you have to answer in exam, and you have to do in practically as well to properly manage a case of postpartum hemorrhage. First of all, postpartum hemorrhage, a single person cannot manage a case of postpartum hemorrhage. Always you call for help. Whoever is around you, just call for help. You need a helping hand for the management of postpartum hemorrhage, because a single person cannot manage a case of postpartum hemorrhage. First thing is the call for help. Okay, when you call your attendant, you call your friend, you call your senior, you call your junior, whoever is there, you call your sisters, whoever around you, just call for help and ask somebody to open the IV line if it is not open during delivery. Okay. Sometimes in the institutional delivery, we keep the patient in the vein open, but sometimes the patient had maybe coming from outside in labor, had just delivered, she might not have IV open access. So open the IV line with the help of your friend or helping hand. Okay, open the IV line. Next is, what do you do is the insert Foley's catheter. Insert Foley's catheter. That means if the patient has postpartum hemorrhage, there are two reasons you have to insert the post-Foley's catheter into the urinary bladder to see the amount of the urine, whether the kidneys are perfused normally or not. Another is, if the patient has full bladder, it hampers the uterine contraction also. So for two reasons, in a patient with primary postpartum hemorrhage, you have to insert Foley's catheter, urinary catheter, into the bladder in order to see the amount of the urine, either this is adequate for the renal perfusion is adequately done or not, or there may be a distended urinary bladder which hampers the uterine contraction. Next is oxygen inhalation. The patient has blood loss, patient has features of hypoxia, patient has low blood pressure, tachycardia. You have to give oxygen instantly, whatever is available, 2 liters per minute of oxygen. You have to start immediately if the patient is having postpartum hemorrhage. Okay, by that time, somebody, when opening the IV line, have to send the hemoglobin and coagulation profiles and blood grouping. If it is not done, sometimes this is not done, unbooked case cannot have like blood grouping also. So see the reports of that particular patient. If the patient has blood grouping, that's fine. Otherwise, you have to send the blood sample for hemoglobin and coagulation profile and arrange 2 pints of 2 packets of the whole blood immediately for those patients who has got postpartum hemorrhage. Okay. Next, start giving oxytocin. 10 units starts in 20 units in the drip. Okay, you have to give 10 units bolus and put 20 units in the drip and slowly infuse. Okay, you have to start with any type of the uterotonic medicine. We talked about different methods, different route of administration according to the drug. You can give whatever uterotonic medicine is available, but before giving ergometrin, methyl ergometrin, you have to rule out heart disease and hypertension. Otherwise, you can give any type of medication for the management of postpartum hemorrhage. Okay. Next is, while giving oxytocin or uterotonic medications, you have to explore the genital tract. By that time, you have to look whether they have trauma or not, trauma to the genital tract or not. Okay, side by side, you ask somebody to examine the placenta also for its completeness, to find out tissue in the uterine cavity causing postpartum hemorrhage or not. Okay, after that, you are with gloved hand do bimanual compression, uterine massage and bimanual compression, and sequential order. One, if doesn't help, go for the higher compression method. You can go for the aortic compression, as I told you how to do aortic compression as well. Okay. Okay, this is how you do till the compression method. Okay, this is done with one person in the labor room can do till the different types of the compression, which can be done from inside or from outside also. Okay, there are certain type of the compression or a surgical method. If that does not help in the patient with postpartum hemorrhage, you have to take the patient to operation theater and you have to apply for the different type of compression sutures. As I told you, billion sutures. Sometimes you have to go for uterine artery ligation. Okay, you just go and open the abdomen, find out the internal iliac artery. From the internal iliac artery, anterior division. From there, you follow the uterine artery and then tie the uterine artery. That is uterine artery ligation. If you do on the both sides, the amount of the blood loss to the uterus will decrease and the patient will have less bleeding or the stop bleeding. Another, if this is a procedure, difficult procedure, if you can do by internal iliac artery ligation, the intermittent type of the internal iliac artery ligation, which also helps in the decreased blood flow to the uterus and decrease postpartum hemorrhage. Sometimes the interventional radiology can be done with the help of the some gel or artery occlusion material can be put into the uterine artery or internal iliac artery, so the blood loss to the uterus is decreased. This is done by radiologists, interventional radiologists. In our part of the world, this is not normally done, but this is a last resort and very sophisticated and very skilled hand procedure, which helps a lot of lives in the developed world also. This is done by occlusion of the artery by radiologist help. Okay, so these are the surgery done after compression and different types of the inside and outside compression. Patient is not responding, you have to take the patient to OT, you have to give general anesthesia, you have to give all the you have to open the abdomen. This even after normal delivery also, you have opened the abdomen and compressed the suture, apply uterine artery ligation, internal iliac artery ligation, and occlusion of the uterine blood supply. Okay, so these are the surgeries done for different types of the postpartum causes of the postpartum hemorrhage. Okay, these are different types of the sutures given for your level. This billion suture is enough, but there are various other types of the sutures. Square sutures in different patchy sutures can be given. It causes contraction in a different part of the uterus. And this is about the primary postpartum hemorrhage. In short, about the secondary postpartum hemorrhage, I told you by definition, secondary postpartum hemorrhage, which occurs after 24 hours after delivery of the baby and which can happen till 6 weeks of preparium. 6 weeks post-delivery period is called the preparium. Okay, if it occurs after 24 hours, patient delivered yesterday, she had no bleeding yesterday but started bleeding from today only. That means after 24 hours, patient started bleeding, and that can extend up to the 6 weeks is the secondary postpartum hemorrhage. Here the amount of the blood loss is not important because we don't expect bleeding till at the end of the preparium. That means till 6 weeks we don't expect any bleeding post-delivery. Actually around 10-14 days after delivery, the vaginal bleeding stops normally. But if the patient is continuously having bleeding, this is also called the postpartum hemorrhage, but this is nothing to do with the amount of the blood loss, like in the 500 ml or 1 liter in the primary postpartum hemorrhage. There is bleeding irrespective of the amount, but still bleeding. This is secondary postpartum hemorrhage. Most important cause of secondary postpartum hemorrhage is the infection. infection causing endometritis. Okay, the patient had a prolonged labor and the patient has multiple mishandling during delivery. The aseptic precaution was not taken properly. Patient was not hygienic. Patient is not taking care of the hygiene of the genital tract. That leads into the infection of the genital tract in the form of the endometritis, which can lead into the secondary postpartum hemorrhage. Another thing, the bit of placental tissue was retained in the uterine cavity. That time she had no bleeding. Later on, that bit of placental tissue gets infected and the patient starts again bleeding as a result of again, that is again due to infection. Sometimes there are certain small laceration in the genital tract. There is a secondary infection and leading into the bleeding from that lacerated or traumatic site. So basically, in the secondary postpartum hemorrhage, the reason or the mechanism of the bleeding is as a result of infection of the either of the tissue or the lacerated wound, or sometimes the open cervix allowing the ascending infection from the vagina into the uterus, leading into the bleeding, which is not normal till the end of the puerperium. The patient is having bleeding is the secondary postpartum hemorrhage. So in the secondary postpartum hemorrhage is basically, I told you, due to infection. So you have to send all the investigations for infections and you have to admit the patient for infection. You have to start broad spectrum antibiotics, and if there is, you have to see whether the uterine cavity contained any needles for infection or not. If there is, you have to explore or you evacuate the uterus to make it empty. If there are a certain infection on the episiotomy site, you have to do wound debridement. That means the cleaning of the episiotomy wound, which helps in to some extent to decrease the infection and the bleeding. Okay, this is how you treat a case of secondary postpartum hemorrhage. Okay, so this is about postpartum hemorrhage. There is a new approach. In short, I just want to mention about the postpartum hemorrhage, which is in the newer approach of the postpartum hemorrhage. Basically, we do the same thing. We start with the uterotonic medicine. We go give all the pressure from outside and inside. We would give all the suturing or things like that. But the things are the same, but they are made to make it easy and convenient for the patient and the healthcare worker. They are divided into the different bundles. This is called the care bundles for atonic postpartum hemorrhage. This is the name of the new approach, is the care bundles. This is just has this is approved by WHO recently in 2019. You guys are not supposed to like, if you know, it's better. Otherwise, it's not hard and fast. You should know all these new methods, but you should be familiar. There is a term called care bundles for the atonic PPS. There are two types. One is first response to PPS and the response to the refractory PPS. This is care bundle is divided into two parts. One is first, as soon as the patient has PPS, you do what are the things you do, and those things are not taking care of that PPS. You go for the refractory response to the refractory PPS. There are the different steps you do in the refractory PPS. Basically, steps are the same, but they are grouped together in two groups for better compliance of the patient. Okay, it includes like packages and checklist, which helps the healthcare workers to adhere and follow the protocol properly so that you can manage the case properly. Okay, what do you do in the first response PPS? All the uterotonic medicine, all the IV fluid, all the medications for tranexamic acid, which are antifibrinolytic agents, and you do uterine massage. These four things are done in the, as soon as the patient is diagnosed to have a atonic PPS, you do these four things for the first response to PPS, which is the first part of the care bundle. Okay. Second is for the response to the refractory PPS. First response is not responding properly, so you have the PPS has become refractory. What do you do is the continuous as the primary approach, which you did in the first response, and go for the compression measures like bimanual aortic intrauterine compressions. And there is a term called, there is a thing called anti-shock garments. When the patient is in the lying down position, you can put the patient into anti-shock garments, which helps in the bringing the blood from the lower extremities to the heart so that the perfusion will be better. That has to be given to all the patient in shock. And the next is the next after refractory PPS, which cannot be handled by the on-duty doctors. That has to be handled by the surgical techniques and expert hand, which has to be done in the operation operation theater. As I told you, the 4 things can be done in the operation theater. So basically, care bundles is divided into 2 parts. One is the first response, and the second is the response to the refractory PPH, and the third is the surgical techniques that needs expert hands and expert hand and all the equipments needed for that particular procedure. So that comes under the care bundle of the postpartum hemorrhage. Okay. Okay. Any question, class? Is it clear? Are you there? Any question? Any question, please? Any question? No question? Clear? Thank you.